Every organ system tells a story, not just of disease, but of how structure determines function, and how understanding normal makes recognizing abnormal almost intuitive. That's the philosophy we'll be following throughout this series. Instead of studying pathology as a collection of isolated diseases, we'll approach each organ system as a complete unit. We'll begin with its normal anatomy, then move through embryology, histology, physiology, cytology, and finally the pathological conditions that affect it. By building this foundation first, you'll not only learn what a disease is, but also understand where it develops, why it behaves the way it does, and how to recognize it with confidence. This playlist is dedicated to the female genital tract. Across the upcoming modules, we'll systematically explore every major aspect of this system, from its normal structure to inflammatory conditions, benign lesions, premalignant changes, malignant tumors, diagnostic pathology, cytology, immunohistochemistry, molecular pathology, and reporting systems. In today's lecture, we'll begin with the foundation of everything that follows, the gross anatomy of the female genital tract. We'll first study the vulva and vagina, followed by the cervix and the uterus, focusing on the anatomical features that are most relevant to pathology and clinical practice. So, let's begin with the external genitalia of the female reproductive system, the vulva. Before we begin, there is one very common misconception that must be cleared. The terms vulva and vagina are often used interchangeably, but anatomically they are not the same. The vulva refers to the external female genitalia. The vagina, on the other hand, is an internal fibromuscular canal that extends from the vulva to the cervix. Understanding this distinction is important because the diseases affecting these two regions are often completely different. Throughout this series, we'll use these terms precisely. Let's begin with the vulva. The vulva collectively refers to all the external structures of the female genital tract. Its primary functions are to protect the deeper reproductive organs, provide the external opening to the genital tract, and contribute to sexual function. From anterior to posterior, the vulva is composed of the mons pubis, labia majora, labia minora, clitoris, vestibule, and finally the perineum. The mons pubis is the rounded pad of adipose tissue situated anterior to the pubic symphysis. Following puberty, it becomes covered with pubic hair and serves as a protective cushion over the underlying pubic bone. Immediately inferior to the mons pubis are two prominent longitudinal skin folds, known as the labia majora. These are the outer folds of the vulva and contain abundant adipose tissue, connective tissue, sebaceous glands, sweat glands, and smooth muscle. Their primary role is to protect the more delicate internal genital structures. Medial to the labia majora lie the labia minora. Unlike the labia majora, they contain very little adipose tissue. Instead, they are thin, highly vascular folds of skin that surround the vestibule. Anteriorly, the labia minora unite to form the prepuce, or hood, of the clitoris. Posteriorly, they fuse to form the fourchette, an important anatomical landmark. Between the labia minora lies the vestibule. The vestibule is the central space into which several important structures open. It contains the external urethral orifice, the vaginal orifice, and the ducts of the greater vestibular glands, commonly known as the Bartholin glands. These glands secrete mucus that helps lubricate the vaginal opening, particularly during sexual arousal. Near the external urethral opening are the paraurethral glands, also known as the Skene glands. Although much smaller than the Bartholin glands, they are clinically important because they may occasionally become infected or form cysts. At the anterior end of the vestibule lies the clitoris. Although only the glans is externally visible, it is important to remember that the clitoris extends much deeper into the surrounding tissues through its body and paired crura. It is therefore a much larger erectile organ than its external appearance suggests. Now let's briefly discuss the vascular supply. The vulva receives its arterial blood supply predominantly from branches of the internal pudendal artery, with additional contributions from the external pudendal arteries. Venous drainage generally accompanies the corresponding arteries. The lymphatic drainage, however, is of particular clinical importance. Most of the vulva drains to the superficial inguinal lymph nodes. This anatomical relationship explains why vulval malignancies commonly metastasize to the groin before involving deeper pelvic lymph nodes. Having understood the external genitalia, we can now move to the vagina. The vagina is a distensible fibromuscular canal that extends from the vulva to the cervix. In the resting state, it measures approximately 7 to 10 centimeters in length, although it is capable of remarkable expansion during childbirth. It is directed upwards and backwards, lying posterior to the urinary bladder and urethra, and anterior to the rectum. One of the most important anatomical features of the vagina is found at its upper end. The cervix projects into the upper portion of the vagina, rather than simply resting above it. As a result, the upper vagina forms 4 recesses around the cervix, known as the vaginal fornices, 1 anterior, 1 posterior, and 2 lateral. These fornices become particularly important during pelvic examination, surgical procedures, and in understanding the spread of pelvic infections and malignancies. The vagina receives its arterial supply primarily from the vaginal artery, with additional contributions from branches of the uterine artery. Its lymphatic drainage varies according to the level of the vagina. The lower 1/3 drains predominantly to the superficial inguinal lymph nodes, whereas the upper 2/3 drain mainly to the internal and external iliac lymph nodes. This difference in lymphatic drainage has important implications in the staging and metastatic spread of vaginal malignancies. With this, we have established the first 2 anatomical components of the female genital tract. The vulva forms the external gateway to the reproductive system, while the vagina serves as the muscular passage connecting the external genitalia to the cervix. In the next section, we'll move to the cervix, a relatively small structure, but one that forms the foundation of cervical cytology, HPV-related disease, and modern cervical cancer screening. As we move further along the female genital tract, we now arrive at one of the most clinically significant structures in gynecology and pathology, the cervix. Although relatively small in size, the cervix serves as the anatomical bridge between the uterus and the vagina. It is also the site from which the majority of cervical precancers and cervical cancers arise, making a thorough understanding of its anatomy essential before we move on to cytology and pathology. The cervix is a cylindrical, fibromuscular structure measuring approximately 3 to 4 centimeters in length. It forms the lower narrow portion of the uterus and projects into the upper end of the vagina. Anatomically, the cervix is divided into 2 parts. The portion that projects into the vagina is known as the vaginal, or ectocervical part. The portion that lies above the vaginal attachment is called the supravaginal part. This distinction is important because each part has different anatomical relationships and clinical significance. The supravaginal part lies within the pelvis. Anteriorly, it is closely related to the urinary bladder. Posteriorly, it is related to the rectuterine pouch, also known as the pouch of Douglas, and the rectum. Laterally, the cervix is surrounded by the perimetrium, through which pass the uterine vessels, lymphatics, nerves, and one particularly important structure, the ureter. This anatomical relationship becomes extremely important during gynecological surgery. A well-known surgical principle states, water under the bridge. Here, the ureter, which carries urine, or water, from the kidney to the bladder, passes beneath the uterine artery, the bridge. Remembering this relationship is essential because the ureter is at risk of injury during procedures such as hysterectomy. Now let's look at the vaginal part of the cervix. During a speculum examination, this is the portion that is directly visible to the clinician. At its center lies a small opening, known as the external OS. The appearance of the external OS varies depending on whether a woman has delivered a child vaginally. In a nulliparous woman, the external OS is usually small and circular. In a parous woman, it typically becomes wider and appears as a transverse slit due to changes following childbirth. The external OS opens into the endocervical canal, which traverses the cervix and communicates superiorly with the uterine cavity through another opening called the internal os. These two openings define the anatomical limits of the cervical canal. Now comes perhaps the most important concept in cervical anatomy. The cervix is lined by two different types of epithelium. The ectocervix, or vaginal portion, is lined by non-keratinized, stratified squamous epithelium, similar to the vaginal mucosa. The endocervical canal, on the other hand, is lined by simple columnar mucus-secreting epithelium. The point where these two epithelial types meet is known as the squamo-columnar junction, commonly abbreviated as the SCJ. However, the squamo-columnar junction is not a fixed structure. Its position changes throughout life under the influence of hormonal changes, puberty, pregnancy, and menopause. As the junction migrates, squamous metaplasia occurs, creating a region known as the transformation zone. Although anatomically small, the transformation zone is of enormous clinical importance. It is the site where most cervical intraepithelial neoplasias and the majority of cervical carcinomas develop. For this reason, cervical screening tests such as the Pap smear are specifically designed to sample cells from this region. We'll study this concept in much greater detail when we discuss cervical cytology and the Bethesda system. Moving on to the blood supply, the cervix receives its arterial blood supply mainly from the descending cervical branches of the uterine artery, with additional contribution from the vaginal arteries. Venous drainage accompanies the arteries and ultimately drains into the internal iliac venous system. The lymphatic drainage of the cervix is particularly important in oncology. Most lymph drains into the parametrial, obturator, internal iliac, external iliac, and common iliac lymph nodes. Knowledge of these drainage pathways forms the basis of lymph node assessment during staging of cervical carcinoma. Finally, the nerve supply. The cervix receives autonomic innervation through the uterovaginal plexus, which is derived from the inferior hypogastric plexus. This autonomic innervation plays an important role in cervical function during menstruation, pregnancy, and labor. With this, we've completed the gross anatomy of the cervix. More than just a connection between the uterus and the vagina, the cervix represents the anatomical foundation for cervical screening, HPV infection, precancerous lesions, and cervical cancer. Understanding its anatomy now will make the pathology that follows far easier to understand. Next, we'll move superiorly to the uterus, the central organ of the female reproductive system, and one whose anatomy explains everything from implantation and pregnancy to tumor spread and pelvic surgery. Having studied the vulva, vagina, and cervix, we now arrive at the central organ of the female reproductive system, the uterus. The uterus is a hollow, pear-shaped muscular organ situated within the true pelvis. It lies between the urinary bladder anteriorly and the rectum posteriorly, making it the central organ around which much of the female pelvic anatomy is organized. Its primary function is to receive the fertilized ovum, support fetal development throughout pregnancy, and generate the powerful muscular contractions necessary for childbirth. In a healthy nulliparous adult woman, the uterus measures approximately 7 to 8 centimeters in length, 5 centimeters in width, and about 2.5 to 4 centimeters in thickness, although its size varies with age, parity, and hormonal status. Anatomically, the uterus is divided into 4 parts. The upper rounded portion lying above the openings of the uterine tubes is called the fundus. Below the fundus lies the body, also known as the corpus, which forms the largest portion of the uterus. The narrow region between the body and the cervix is called the isthmus. This relatively small segment becomes particularly important during pregnancy, where it contributes to the formation of the lower uterine segment. Finally, the inferior cylindrical portion forms the cervix, which we have already discussed in detail. Now let's look at the normal position of the uterus. In the majority of women, the uterus is both anteverted and anteflexed. These two terms are often confused, but they describe different anatomical relationships. Anteversion refers to the forward inclination of the entire uterus relative to the axis of the vagina. Anteflexion, on the other hand, refers to the forward bending of the body of the uterus over the cervix. Together, these positions place the uterus comfortably over the superior surface of the urinary bladder. Although anteversion and anteflexion are considered the most common positions, variations such as retroversion and retroflexion are also normal anatomical variants and are encountered in clinical practice. Moving on to the external features, the uterus has an anterior surface, a posterior surface, 2 lateral borders, and 2 cornua, where the uterine tubes enter the uterine cavity. These anatomical landmarks become important during imaging studies, surgical procedures, and the assessment of congenital uterine anomalies. Now let's discuss the supports of the uterus. Despite being a freely mobile organ, the uterus is maintained in its normal position by a combination of muscular support, fibromuscular ligaments, and peritoneal folds. The most important support is provided by the pelvic diaphragm, which forms the muscular floor of the pelvis. Additional stability is provided by several ligaments. The cardinal ligaments, also known as the transverse cervical ligaments, provide one of the strongest mechanical supports to the cervix. The uterosacral ligaments extend posteriorly from the cervix toward the sacrum, helping maintain the normal uterine position. The round ligaments pass from the uterine cornua through the inguinal canal to the labia majora, contributing to the maintenance of anteversion. The broad ligaments are double folds of peritoneum that extend from the uterus to the lateral pelvic walls. Although commonly described as uterine supports, their primary role is to stabilize and suspend the uterus rather than provide significant mechanical support. Understanding these supporting structures is essential because weakness of the pelvic floor or supporting ligaments may eventually lead to uterine prolapse, a topic we'll discuss later in this series. Now let's examine the blood supply. The uterus receives its principal arterial supply from the uterine arteries, which arise from the anterior division of the internal iliac arteries. As each uterine artery approaches the uterus, it ascends along its lateral border, giving rise to numerous branches that supply the body and cervix. Near the upper part of the uterus, the uterine artery forms an important anastomosis with the ovarian artery, which arises directly from the abdominal aorta. This dual arterial supply helps maintain adequate perfusion of the uterus under varying physiological conditions. Venous drainage occurs through the uterine venous plexus, eventually draining into the internal iliac veins. The lymphatic drainage of the uterus deserves special attention because it directly influences the spread of gynecological malignancies. Unlike many organs that drain to a single nodal group, the uterus has multiple lymphatic pathways. The fundus primarily drains to the para-aortic lymph nodes, following the course of the ovarian vessels. Some lymphatic channels accompanying the round ligament reach the superficial inguinal lymph nodes, an important anatomical exception that occasionally explains inguinal nodal involvement in uterine malignancies. The body of the uterus drains mainly to the external iliac lymph nodes. The cervical region, as discussed previously, drains predominantly to the internal iliac, external iliac, obturator, parametrial, and common iliac lymph nodes. Remembering these drainage pathways will make understanding the staging and metastatic spread of uterine cancers much easier. Before concluding, there is one surgical relationship that every medical student should remember. As the uterine artery crosses toward the uterus, the ureter passes beneath it. This relationship is classically remembered by the phrase, water under the bridge. Here, the ureter carrying urine, the water, passes beneath the uterine artery, the bridge. This is one of the most important anatomical relationships in gynecological surgery because inadvertent ureteric injury may occur during procedures such as hysterectomy. With this, we have completed the gross anatomy of the uterus. We have identified its parts, understood its normal position, examined its supporting structures, and explored its vascular and lymphatic anatomy. Together with the vulva, vagina, and cervix, these structures form the anatomical foundation upon which every subsequent topic in female genital pathology will be built. In the next module, we'll move even further back to the embryological development of the female genital tract, where many congenital anomalies, developmental disorders, and even certain pathological conditions begin their story.